Up to 20% of all strokes are caused by thromboembolic events associated with atrial fibrillation. Anticoagulation has been shown to be effective in reducing thromboembolism, but has risks such as increased risk of bleeding and is contraindicated with certain comorbidities. Left atrial appendage occlusion devices such as the Watchman have been demonstrated to be beneficial in this population. This presentation is over the utility of transesophageal echo for Watchman implantation. We're going to be covering windows, different measurements that are used, along with some of the assessments, including monitoring for complications. The Watchman may be used to isolate the left atrial appendage. Made by Boston Scientific, about the size of a quarter, the Watchman is shaped like a parachute and is implanted in the left atrial appendage to prevent clots from forming. Fluoroscopy and echocardiography are currently used to guide the procedure. Transesophageal echocardiography, or TEE, is the main imaging modality used in placement of the Watchman and is used to assess for anatomic left atrial appendage variations, guide the atrial septostomy and Watchman placement, evaluate the final device position, and monitor for the occurrence of complications. Intracardiac echo, or ICE, is also utilized to improve Watchman landing and device size selection. In this presentation, we focus on current imaging approaches using TEE. Implantation of the Watchman follows a routine sequence. First, the femoral vein is cannulated and a guide wire advanced to the atrial septum. The atrial septum is then crossed under TE and fluoroscopic guidance, and then a large sheath is advanced over the guide wire into the left atrial appendage, and its position is assessed with TE. A smaller sheath with a Watchman device is then advanced through the larger sheath into the left atrial appendage, and the device is deployed. Then the position and stability of the device is verified with fluoroscopy and a TE using a tug test, which we'll see momentarily. Finally, complications from the procedures such as effusion, pericardial effusion, mitral valve compression, or left upper pulmonary vein compression are ruled out. As mentioned previously, the utility of transesophageal echo for Watchman includes pre- and peri-procedural support of the device implantation. First, you're going to verify a clean appendage. You're going to look for atrial thrombus. You're going to be looking for smoke. You're going to be looking for color, flow indications, and pulse wave Doppler indications of thrombus. You're also going to identify the left atrial appendage shape, whether it's cactus, broccoli, chicken wing, whatever, windsock, along with the maximum orifice area. You're going to be making some measurements to help size the Watchman device. You're also going to assist with the trans-septal puncture. You're going to typically going to use a biplane, X-plane, whatever you want to call it, and assist with a safe trans-septal puncture. You're also going to verify the presence of the pigtail from the large sheath that comes up from the femoral vein in the left atrial appendage itself. You're going to do some, they also use some contrast and fluoroscopy. You're also going to assist with the tug test, and you're going to rule out leaks and look at the width of the shoulder of the Watchman device to make sure that there's good compression based on the size of the device and whether it fits nice and snug into the left atrial appendage. And finally, you're going to assess for pericardial effusion, mitral valve abnormalities like regurgitation. You're also going to look for left upper pulmonary vein flow to make sure there's nice flow, because sometimes you can kind of jail the left upper pulmonary vein with the Watchman. And you can kind of see here you got a nice little effusion going on here. You got a little atrial bounce, and you can kind of see the outline of the pericardium in this nice anechoic area here. The left atrial appendage view is used to assess for left atrial appendage pathology, the morphology of the left atrial appendage, and used to make some measurements. And it's not just the one view. You're actually using 4 views to make the measurements, and we'll talk about that momentarily. But the left atrial appendage view is obtained a number of ways. There's a couple of different ways. One of the more popular ways is just to insert the probe to the mid-esophageal, either the right ventricular inflow-outflow view or the aortic valve short axis view, about 40 to 60 degrees omniplane. Then rotating the probe to the left and identifying the left atrial appendage. And then to identify the left upper pulmonary vein for this position, the TE probe is withdrawn slightly or maybe antiflexed, depending on your preference. And then using 2D TE, left atrial appendage diameter and length, along with neck dimensions, are measured during diastole in several planes. Typically, these are 0, 45, 90, and 135. As you can kind of see here, you've got the left atrium, which is always the closest to the near field, which is where the beam comes out of the TE probe in the mid-esophagus. You've got the left atrial appendage over here. You usually have to turn the probe a little bit to the left to get there. There's your interatrial septum here, right atrium, mitral, tricuspid valve, right ventricle, aortic, right above the aortic valve, pericardium here. And the typical diameter is about 1.6 plus or minus a half centimeter of the left atrial appendage, a length of 2.9 plus or minus 5 centimeters, 0.5 centimeters. It's also very nice to get this view for the atrial septostomy view, depending on what your preferences are. In assessing the morphology of the left atrial appendage with TE, there are enormous variations in left atrial appendage shape, orifice diameters, length, volume, and number of lobes. Left atrial appendage is usually bent or spiral in shape, and greater than 50% of the left atrial appendage have more than 2 lobes. So you have a left atrial appendage that's typically divided into 3 regions. The ostium region, which is elliptical rather than round, close to the mitral valve and left upper pulmonary vein. The neck region, which is the landing zone, which is very close to the circumflex artery. And the lobar region, which is the largest and most variable and can include chicken wing, hooked, broccoli, cauliflower, windsock, etc. Typically, you're going to measure all of these regions. The ostium, which is the most wide portion, but is actually rather elliptical, along with the neck or landing zone for Watchman's sizing. So there are different morphologies, and they're classified actually based on what they seem to be. But these are the most common: the windsock, chicken wing, broccoli, and cactus. But it's kind of self-explanatory. This is a nice long unilobed left atrial appendage, which is very amenable to Watchman implantation, versus the chicken wing, versus the broccoli, versus the cactus. And these are in increasing order of difficulty in implantation. Prior to measuring morphology, you assess for thrombus and flow. Here you put a little color on the left atrial appendage to verify that there's flow. Then you put a little pulse wave Doppler on here, and you get nice measurements of flow in and out of the left atrial appendage. You can also look for smoke, spontaneous contrast, etc. But it's a very important thing to do, because if you've got some clot in there, you obviously have to come back another day. At this point, the left atrial appendage is interrogated for sizing of the occlusion device. You're going to basically freeze the image during diastole, and then you're going to take some calipers and you're going to measure the diameter, and then you're going to measure the depth of the left atrial appendage for sizing. And this is in the 45-degree angle. You're also going to measure in the 0, the 90, and the 135-degree angle. And here our measurements are listed as 1.43 centimeters and 3.14 centimeters. Precise knowledge of the dimensions of the landing zone is particularly important in selecting the appropriate device size. When 2D TE is used for sizing, measurements must be performed in multiple planes. And you may say to yourself, well, why don't we just use 3D TE? And some people are using 3D TE, but in general, industry-wise, pretty much the 2D measurements are what's used for sizing, and it just hasn't really taken off yet. But it sounds like a great thing. But when 2D TE is used for sizing, you're typically having to use and measure in 4 different planes: 0, 45, 90, and 135 degrees. And you're going to end up choosing the largest size diameter in all 4 of these planes. The measurement of the landing zone should be performed from the inferior part of the left atrial ostium at the level of the circumflex artery, to a point 1 to 2 centimeters distal to the tip of the rim to the left upper pulmonary vein, or the ligament of Marshall. Typically, a left atrial appendage width of 17 to 31 millimeters is required. And these are the measurements at 0 and 45 degrees. And so what we've done here is we've measured here and here, and we've got 1.59 centimeters and 2.86 centimeters versus here and here, which is 1.5 and 2.77 centimeters. And as always, the left atrium's in the near field here when you're in the mid-esophagus, and the neck and lobar depth measurements are made prior to the ostium with the use of calipers during diastole. Again, at 90 and 135 degrees omniplane, there's 90 and there's 135. Measurements again made of the left atrial appendage. Here we've got 1.45 and 2.33, 1.67 and 2.38. These measurements may be a little bit on the low side because it is, again, using a HeartWorks simulator. And then precise knowledge of the dimensions of the landing zone is particularly important in selecting the appropriate device size. To ensure proper device engagement with the left atrial appendage wall and to guarantee stable and safe device positioning, the device size is usually chosen to be a few millimeters larger according to the instructions for use for the different device types. I think it's a little bit different with the amulet than the measured appendage diameters. Echo is of major value in determining the preferred puncture site in the intraatrial septum to avoid complications, but also to have the correct angle. The intracardiac echo is used for atrial fibrillation cases a lot of times, and other electrophysiology procedures. But in general, TEE is very useful for the for Watchman, as you get other utility of the TEE as well, including some of the utility of looking at mitral valve, looking at left upper pulmonary vein, and making the assessments of the left atrial appendage. A short axis view at the base in 2D TEE imaging at 45 to 60 degrees here allows for orientation in an antero-posterior direction, and a long view axis at about 135 degrees, or a modified bicable view, actually, because there's bicable being both the cava being the left atrium, right atrium, the SVC, and then the IVC coming off here, provides orientation in the superior, inferior, or the cranial and caudal directions. And in 3D X-plane, which is basically a volume instead of just a single slice, allows imaging in short axis view at the base and a bicable view simultaneously, thus facilitating trans-septal puncture. So you're basically just lining this up right here on this septum, and you can see the tenting from the atrial septum as you cross over. And in this 2D TEE clip, the septostomy is guided by fluoro and by echo, so you can actually see the atrial septum being punctured here, and then the needle coming across, and then you can see the same thing over here in this modified bicable view. And while it's not true 3D TEE, the different planes offer additional information. Very high utility. While there's several types of left atrial appendages morphology, the three most common type include the broccoli, which you see here, which looks a little bit like a broccoli stalk, the chicken wing, which is kind of bent, along with the windsock, which is a nice long tube, which is much easier to implant a Watchman than the other morphologies. Once access to the left atrium is achieved, a sheath is advanced into the left atrium and a pigtail catheter is inserted into the left atrial appendage over a soft wire. TEE and fluoroscopy are used to monitor the introduction and the position of the delivery sheath into the left atrial appendage. And then the device is deployed by retracting the delivery sheath. The Watchman should be in alignment with the major axis of the left atrial appendage. To release the Watchman, the core wire is unscrewed, and then the delivery sheath is removed. You do a quick TEE exam to make sure you aren't jailing the mitral valve anterior leaflet or the left upper pulmonary vein, and then over the course of time you have epithelialization, and the Watchman does its job. Fluoroscopic and TEE assessment of Watchman position verifies successful and optimal implantation. Several fluoroscopic and endocardiographic parameters are used to determine a correct and stable device position, as mentioned before, but you can kind of see the tug test here on fluoroscopy. Right over here, you're kind of tugging to make sure it doesn't come off. And as well, you're looking for TEE assessment. You're looking for any type of leak around the Watchman itself. And here's the mitral valve over here. You see there's not a good deal of MR. We'll also look at the left upper pulmonary vein before we're done as well. Complete coverage of the left atrial appendage should be assessed, and any interference with neighboring structures such as the left upper pulmonary vein or the mitral valve should be ruled out. Color flow Doppler with a low Nyquist limit, 30 or so, 23 even, should be used to assess for peri-device leakage and persistence of communication between the left atrium and left atrial appendage. We'll show you that in just a moment in evaluating for that. Watchman devices have to be implanted so that the device is positioned below the left atrial appendage ostium or at the osteal plane. Too deep into the left atrial appendage carries a potential risk that more proximally located lobes are not covered, and then too high, like protruding outside of the left atrial appendage, may not be stable, and you may end up losing the device. So in this slide, we're going to put some color flow and pulse wave Doppler on the left atrial appendage and assess for residual flow. Here you can see we put a little color on there, and there really is nothing going in and out of the left atrial appendage and the left atrium across the Watchman. Put a little pulse wave Doppler on it, and there's no flow in the left atrial appendage either. So pretty much verifying that we have a good result. Complete coverage of the left atrial appendage should be assessed, but also you need to be looking at the effect on neighboring structures such as the left upper pulmonary vein or mitral valve. A device placed in the left atrial appendage can theoretically compress the left upper pulmonary vein, as you see over here, although obviously we've got good flow there, or alter the mitral valve apparatus such that you need to be looking for some type of regurgitant flow here across the mitral valve, usually the anterior leaflet. Therefore, pulmonary vein anatomy and vein flow should be evaluated by color flow, but also with pulse wave Doppler. You can put pulse wave Doppler right there, a nice little sampling box. And similarly, the mitral valve anatomy should be assessed in detail before and after the procedure, looking for some type of complications and ruling that out. So in conclusion, echo, mainly 2D echo and some 3D in some centers, is currently the imaging modality of choice for left atrial occlusion devices. Pre-procedural assessment may be done in a TE lab, but assessment typically is made during the procedure for precise dimensions at the bedside or in the OR, which makes it a lot more efficient. TE guidance for Watchman insertion requires a multidisciplinary approach involving anesthesia, cardiology, and proceduralist.